the hallway. And I was like, who's doing this stuff? And I don't know who they are. So it's really nice to meet you. I'm Sabla Kasai. I'm also at Georgetown, and I am one of the multiple PIs on the Max-Wise combined cohort study. So used to be the WISE, and now also the STAR study, which is the young women with and at risk for HIV, our young cohort. So, and then does our team want to introduce themselves so everyone knows you? Larry?
Hello, everyone. I'm Larry Warner Jean-Pierre. I'm the one who sent out the reminders, and hope I didn't bombard you with them. But I work with Sebla as the project director for the Young Women's Study, and I am also the CPS core manager. So it's nice to be here. Thank you.
Larry's a sociologist, so we're always happy to have her working with us on our studies, because many of the challenges we continue to face are not purely biologic. So, Manya?
Hi, everybody. I'm Manya Magnus. I'm at George Washington University. I'm delighted to work on the CPS core with the CPS core team, and I do epidemiologic study design. So if you have questions or need help, just send them my way.
Thank you. And Sam?
Hi, I'm Sam Simmons. I'm at GW as well, and part of the CPS core. So I had our biostatistical support. So if you haven't worked with me in the past or worked with us for biostatistics and you need some help, please be sure to contact me.
So thank you. So that's kind of our core CPS group, and thank you to all of everybody who signed up to come. I see some repeat customers. In the interest of time, if we can just do a quick introductions, where your location is and type of research you do, that would be great. So I see Adeline.
Hi.
Hi,
Hang
Adeline.
on. I'm just getting a snack while everyone's talking. Sorry, so inappropriate. But my name is Adeline. I'm one of the PEDS ID attendings at Children's National. Also have an adjunct position, or actually faculty position at GW. The main work that I'm doing has kind of been all over the place a little bit, but gut microbiome work, systemic inflammation, and now looking at more intervention related work to help improve health outcomes of our youth living with HIV. I'm looking forward to hearing this talk.
Great, thank you. And Faru? Olujimi? Oh, please don't disappear because I call your name. I just want everyone to know each other. So rejoin, don't feel forced to speak. And, but we do have two wonderful, I think everybody else has introduced themselves. And then we have two wonderful speakers today, people who are focused on looking at neurocognition, which is a huge concern in women and people living with HIV. And I think for the younger children, cognition is also a really important, but maybe a little bit difficult and harder to study kind of issue. But certainly I know that there are issues that have occurred in that setting. So I will go ahead, and if I was going to ask Blair to present her work, because I think it gives kind of a little bit of a background from some of the work we've done in WISE, and then move on to Zhang, because Zhang, I think you have both the cognition data and a lot more imaging data, and I think it's beautifully complementary. And the main objective of these conversations really is to stimulate discussion, ideas for collaboration. And so we usually do like for our if basic scientists are present or even social scientists are present, to think about what direction we need to go in to help improve outcomes. So I'm glad we have a nice mixed audience here today. So without further ado, Blair, do you mind getting us started? So Blair is an assistant professor at Georgetown in the Department of Medicine, Infectious Diseases, and she's one of our faculty in the DC Max-Wise combined cohort study. Thanks, Blair.
All right, no problem. Let me just share my screen. All right, is everyone able to view my slides?
Yes.
Okay, perfect. Okay. So, my name is Blair Spence, as was just introduced, but I'll be presenting a little bit of the work I did looking at cognitive disorders in women living with HIV using the MWCCS data. So I know this is a well-versed audience, but just a little background. So in some studies, over half of people living with HIV have cognitive impairment. And with the development of virologically suppressive ART and the resulting immune restoration and preservation, AIDS-defining illnesses, including HIV-associated dementia, are now fairly rarely seen in people that have access to antiretroviral treatments. However, mild forms of cognitive impairment continue to persist and have been described in those that are otherwise effectively treated with peripheral virologic suppression. But really, data is more limited in women living with the virus, and either they're excluded from studies or they're underrepresented in studies. And really what we found in the limited data that's available is that women tend to be, or seem to be at least, more cognitively vulnerable than men. And you can see here, let me see if I can get my cursor together, on this figure on the right. I think it's a very nice representation of the multitude of factors that affect cognitive impairment in people living with HIV. So it's actually published in Lancet. It's by Alan Winston and Serena Spudich. And it shows that there's lots of different insults that affect the cognition in the brain in people living with HIV. Some are active and ongoing, or some can be like legacy effects related to early viral infection. And they can include anything related to comorbidities such as metabolic disease, cardiovascular disease, neurodegeneration of aging, direct viral effect in CSF escape or viral persistence, neuroinflammation, and substance use. And the area that I was most interested in was antiretroviral toxicity and the effect of antiretroviral use on cognition in women living with HIV. And really, my goal was to develop an understanding of the effects on cognitive disorders of ART among women living with HIV, as these are currently the only effective treatment strategies that we have for HIV-associated cognitive disorder. And so truly understanding the effect of these medications on cognition is critical to developing effective treatment strategies. And as I mentioned before, overall ART definitely improves health outcomes, viral suppression, and has reduced the prevalence of cognitive disorders. But there's evidence that there's direct neurotoxicity of ART, which has classically been associated with older agents used to treat HIV. But we're starting to see neuropsychiatric symptoms and cognitive deficits related to newer agents such as the integrase inhibitors. And so ultimately understanding these effects will help to develop effective treatment strategies. So I put this as kind of a big picture goal. Obviously this presentation won't answer all of these questions, but really this will help to understand the mechanisms of the effects of ART on cognition, or at least develop a platform to do that, and ultimately develop and implement effective treatment strategies. And so the first step was to look and understand the prevalence of HIV-associated cognitive disorders in treated women living with HIV. So we utilized the data from the MWCCS, or the women that were enrolled in the former WISE study, for this analysis. And I think most people in the room are familiar with the study, but it's the largest study of women living with HIV, and it provides a representative sample of women living with the virus in the US. And there's a validated cognitive assessment that was implemented in 2009 amongst all women enrolled in the study, and it's completed biennially. So there's almost 10 years of cognitive data now. So what we did was we assessed what the prevalence was of cognitive impairment in treated women living with HIV. And so the first column that you see on the left is impairment at the index cognitive assessment. And so total, there are almost 1,200 women that we found with a median baseline age of 47. So it was a relatively young group of women, and they contributed 3 median cognitive assessments. So it's about 6 years worth of data here. And so at the beginning of follow-up, or the index assessment, should I say, about 22% of women had global cognitive impairment. And you can see here there are various amounts of impairment in the other cognitive domains. So 19% in executive, 13% attention, 14% in cognitive processing speed. And then when you look at follow-up, there was increases in the amount of impairment within the cohort. So at the last cognitive assessment, 29% had global impairment. And there were significant increases in the verbal learning domain, up to 23%, verbal memory at 21%, and attention at 18%. So clearly, there's cognitive impairment in this relatively young group of women. However, it's difficult to compare this group to other groups with cognitive impairment because no one is really studying cognitive impairment in women this age. So if you look at other studies, for example, if you look at an assessment of community dwelling elderly, 23% of them had cognitive impairment. And these were a group that were over age 65. And then if you look at data from the ADAMS study, which is the Aging, Demographics, and Memory Study, and so their ages were over 71. And when you looked at cognitive impairment in those without dementia, so this excludes any dementia, those were 22%. So these are rates of cognitive impairment of patients that were much older than our cohort. So it's definitely an issue that's ongoing with the population as they age. And so the next assessment was looking at drug exposure and understanding how drug exposure affects cognitive impairment over time. And so we used class-based drug exposure. So we looked at women that were exposed to the different classes of medications, including the NNRTIs, the protease inhibitors, and the integrase inhibitors. And in order to have kind of a clean background, we excluded any person that was exposed to any other drug of interest. However, they could be on an NRTI backbone. So for example, someone that was in the NNRTI group would have never had any exposures to protease inhibitors or integrase inhibitors. Or those that were in the protease inhibitor group would not have any exposures to the integrase inhibitors or the NNRTI group. And so the numbers are smaller here because we wanted isolated drug exposures. So the highest number of women were with the NNRTI group at 247. Amongst those exposed to protease inhibitors, 219, and integrase inhibitors, 79, which is what we expected based off of the rollout of the respective antiretroviral drugs. There were significant differences in the ages of the participants. So women that were exposed to the integrase inhibitors were older at age 50 versus those in the NNRTI or the protease inhibitor group. And those in the integrase inhibitor group also had less drug exposure with an average of, a median average of 3.5 years versus 8.7 years and 6.7 years of the other drugs. They all had similar mean years of HIV diagnosis at about 21 years. So there may be some selection bias as far as the treatment effect. The other categories, for the most part, were relatively similar, with with the exception of the incidence of AIDS-defining illness, with more incidence of AIDS-defining illness amongst those in the NNRTI group or the PI group, which may have driven the implementation of antiretroviral therapy at that time. Comorbidities were similar amongst groups. I didn't show it on the table since the table was getting a little bit large for this, but diabetes, hypertension, depression were all similar amongst the groups. The only thing that was different that wasn't depicted on this table was the amount of illicit drug use, which was higher in the NNRTI group. And so the next step was to look at the changes in cognition over time amongst those that were exposed to the different drug classes. And in this model, we adjusted for hypertension, depression, and AIDS-defining illness. And what we found is what really stood out was the NNRTI, and it was a somewhat unexpected finding, is that women that were exposed to NNRTIs actually had improved learning over time but this didn't pan out with the integrase inhibitor or the protease inhibitor group. But what was also interesting to us was that there were a trend toward worse verbal memory and fine motor outcomes amongst those that were exposed to the integrase inhibitors. Now, if you remember, oh, whoops, I didn't mean to skip my slides. Now, if you remember the slide before, there were significant differences in the timing of drug exposures between the groups. So we elected to do a sub-analysis to look at time-dependent changes related to drug exposure, thinking that maybe the exposure to drug could affect outcomes. And we used a cutoff of 3 years as the median time of integrase inhibitor exposure was about 3.5 years. And what we found was when we compared those that had been exposed to less than 3 years versus those that had been exposed to more than 3 years, those that had NNRTI drug use had worse attention, which seemed counterintuitive, and those that were exposed to the integrase inhibitors had worse psychomotor processing speed. And so now that I think about this slide, maybe I should have reassessed it a little bit. But, you know, I think that we're beginning to see changes related to cognition in this aging group. And there's definitely signal that that there's drug that contributes to the cognitive trajectories of women living with HIV. But I think it does require ongoing longitudinal characterization as they age and have further accumulated drug exposures to fully understand the effect of and the compound effect of drug exposures, both at a population and at an individual level, as we're definitely seeing heterogeneity in response to ART, which has been shown in other work that's been done within the MWCCS that I didn't present here. And it could be related to pharmacogenomics, drug metabolism, and/or interactions. And we are doing some work related to genetic markers and antiretroviral use. And then as they age, it's also important to try and differentiate other causes of cognitive impairment. While it may not be an issue at age 47, trying to tease it out in someone that is 70 is a different thing. And then finally, to get a full picture, we do need to assess the effect of ART on immune recovery, neuroinflammation, and brain structure and function. And I think that kind of leads into our next talk, and then I'll stop here. Oh, my thank yous. That's the most important part. So I'd like to thank mostly the women that participated in the MWCCS, and then all of the group at Georgetown University, the Hopkins Brain Health Group, and of course the DCCFAR, as this work was supported by a DCCFAR pilot. Okay, I'll stop.
Thank you, Blair. Do we have questions for for Blair, and we can either take them now. And again, Zhang's work, I think, is hugely complementary and builds on this with amazing imaging. So any questions for Blair, clarifications that people would like to ask about, thoughts on additional things she should consider? Because her goal really is to use this data. She submitted this, or on the verge of submitting this manuscript now for publication, and will be using this formative work to support grant applications in the future. So we're happy to hear anybody's thoughts or questions that would help her.
I see Dr. McGuire had her, Dr. McGuire's eyes, excuse me. Had her hand
Yeah, just Kathy, that's fine. I'm not sure my question is going to be helpful to your grant. It was just for my own understanding. Have people done studies to show that those drugs are toxic directly to neurons, like in culture, and do they cross the blood-brain barrier, and is that the effect, or is it like the peripheral immune response that's being affected there?
So it's kind of a mixed bag. So definitely the older drugs, particularly the NRTIs and the NNRTIs, have been shown to be neurotoxic, and they've looked at it biologically in more basic science ways. But as far as I'm aware of, there haven't been detailed studies on the newer classes of medications, including like the integrase inhibitors, and then some of the newer generations of the NNRTIs. The protease inhibitors have been studied as well. And then when you look at looking at the blood-brain barrier, so that's an interesting question that you have, because I'm very interested in understanding penetration into the blood-brain barrier and its influence on ART exposures. So there's something that's called the CPE. So it's the Central Nervous System Penetration Score. I can't think of what the E stands for off the top of my head. And it's a rating of how well medications penetrate into the CNS. And really, when they've done studies, it hasn't correlated well with cognitive outcomes in all studies. So some studies say, yeah, if you give drugs with high CPE scores, you may get a little bit better cognitive outcome. Some say maybe not so much. So it's a really mixed bag. But if you look at the blood-brain barrier, I don't think we truly understand how the blood-brain barrier changes throughout HIV infection. Because early in HIV infection, the blood-brain barrier can have damage. But what happens after you've chronically been infected with HIV? It's kind of a question. And I think understanding the penetrance of the drug, the blood-brain barrier, I think is critical.
Yeah, I mean, I'm super interested in that, just because we study astrocytes that are so important to maintain that blood-brain barrier, and some direct effects of HIV-related proteins on those astrocytes to release matrix metalloproteinases, which will affect the whole system. But I hadn't really thought about the angle of what the current therapy might be doing to actually maybe exacerbate what we're seeing in the astrocyte function. So I don't take a lot of time, but sometime
I think that would be a great thing to look at more. So if you in an in vitro model, if you're able to demonstrate that direct effect, that would really be pretty compelling. A lot of the things we look for are fairly indirect because of sampling issues.
Sure.
But I think, these are exactly the kind of discussions and potential collaborations that I think we're hoping to stimulate with these discussions, and supporting, junior faculty in your group to design and come up with something. I think that would be a win-win for everybody.
Yeah, thanks.
We have two questions in the chat. The first one is, what was your sample size for less than 3 versus greater than 3 years for NNRTI and instant comparison?
I don't want to tell you the incorrect number, and I don't recall off the top of my head, but I'll get it back to you. I will email you.
Thank you.
And yeah, I was just really thinking about
Mhm.
whether you've got potentially, if it's a small sample size, could your data be a little bit skewed, and that's why the results are just not what you had expected.
It could be, and because you remember that the overall group for the the integrase inhibitor group was smaller than the rest of the group. So there could be skew with that, and that may contribute to some of that. I think ultimately what we do need is a larger group with INSTIs.
And the second question are there any studies about cognitive impairment in men living with HIV compared to women?
So when you look at studies, not that I'm aware of that directly compare it, the studies that I'm aware of look at them in concert with women living with HIV. But I think the thing to think about when you're thinking about men living with HIV and women living with HIV, at least in the MWCCS, which is fairly reflective of the population of people living with HIV in the country, is that the men it's a very different group than the women. They have different comorbidities. For example, women in the cohort tend to be higher rates of obesity. The women are a little bit younger than the men living with HIV. So I don't know that it's a direct one-to-one comparison.
And Blair has been speaking with, our cohorts are only newly merged, and Dr. Becker, who's at Pittsburgh, ran a lot of the men's neurocognition studies. So he is helping to support her and wants her to look also at these antiretroviral effects on men and their cognition. So this is something that we do hope that we'll be able to have something that's, a good comparison using large observational data sets. The San Diego group, who Zhang collaborates with very closely, also do have cohorts of people that they study, including men and women. But again, this focus on antiretroviral drugs is not something that has been done in most other studies because of, these are people who had incidental onset of use of drugs and agent that we are able to document very well in the cohort because they were enrolled and maybe started on these therapies, and we had data on these individuals. Blair, go ahead, correct me. But so I think it does give a pretty unique opportunity to study these things because we have the treatment histories well characterized and many years of cognitive data in addition to, as well as reposited biomarkers that we can, or samples that we can run biomarkers on. Blair, anything to add? And
no, I don't think I have anything to add.
Yeah.
I don't want to take up too much of Zhang's time.
yeah, because Zhang has a lot of beautiful material to show us.
I think Blair, it's a great talk. Yeah, it's like we should discuss more after meeting. Yeah? See how we can, because we do get some patients from you guys.
Yeah.
From WISE, so now it's almost 8 years now, 8 or 7 years.
That's right.
So we should say whether the image data we have back then can predict the current situation. That'd be cool. Yeah.
Right. So thank you, Zhang, for joining us. So Dr. Zhang Zhang is an associate professor, I believe, at Georgetown.
I'm sorry, correcting, one assistant professor. Yeah. No.
You're associate, right?
Assistant.
Oh, okay. So he's going to be promoted soon, we hope. He should be, because he's doing amazing work. And he's worked with the WISE previously with Dr. Young, and then we continue to support his efforts. I know he's worked with Dr. Manya Magnus also, and both Georgetown and GW have worked very closely with Zhang for recruitment of participants. And his focus really has been on neuroimaging, again, trying to contribute to our understanding of neurocognition and neurocognitive disorders in people living with HIV. So Zhang, go ahead, please.
Okay, thank you, Silo. I'm sharing the screen here. Okay, can everyone see the screen here?
Yep, looks good.
Okay, great. So actually, yeah, thanks, Silo, and also thanks to Silo for the invitation. This is a talk I gave to Sibo's group back about 1 month ago. But yeah, that's great. That's the talk is have like 70 or 80 slides. So I cut down quite a lot, remove like 2/3 of them. So today I'm going to just focus on one imaging modality, but we also, at the same time, I still will touch all the other technique and see also from myself as an imaging perspective, what we can do to help to understand HIV brain disease, what we can do to help people with being affected by this disease, how we can be able to identify the cause. Eventually, maybe we can lead to something like a treatment to help them to preserve or to even to improve their function, so we can improve their quality of life. I guess since you guys everyone is familiar with this one, so we're going to skip pretty much. So this is a very nice document of the HIV prevalence, and also let me see that nowadays, thanks to the combination antiretroviral therapy or CART, now we have really many of the individuals living with HIV disease actually have really very health situation. I would say to some degree, probably they are healthier than some of the HIV unaffected individuals, at least in the cohort we are studying. But at the same time, and also their life expectancy is matching with the HIV unaffected individuals. But at the same time, they still have some, still fairly behind. And the more problem is they have many, for community free, as you can see, there is a huge difference compared to just overall life expectancy. Many of them are being affected by comorbidities such as chronic disease, diabetes, cancer, and of course, for us to study is hand. That's my basically my research to study with imaging. I'm going to skip this one as well. With hand, hand is purely defined at this stage. Even we try to use imaging or use blood biomarkers or use CSF biomarkers. But as of today, hand is still pretty purely defined by behavior impairment, neurobehavior impairment. So we run a quite intensive neuropsychology battery, then we assess in all the performance. Then we, of course, we need to normalize based on the demographics. Then we give them a score. And this will be 3 stages of hand. The first is mild stage will be NI. And then the next stage will be MND. They will have some interference with daily functioning. And this will be the most severe form of the hand or HIV-associated dementia. And thanks to the CART, as you can see from here, pre and post-CART, the incidence of the most severe form of hand HIV-associated dementia is significantly reduced. At the same time, their life expectancy also increased a lot. But of course, at the same time, what's positive or what's remaining a big challenge is the overall, the prevalence of hand is pretty much stay unchanged. You can see there's for the more mild forms of the hand, actually, the incidence actually increased. The many potential factors we still try to understand, like aging, like the disease duration, or some other comorbidities as well, including the antiretroviral medication they're taking as well, because as Dr. Spence just discussed, right, with different medication, they might have, because of the cause of the blood-brain barrier breakdown or other problem, they might be neurotoxic, so they can impair with the neural function. This is another recent meta-analysis study with many different concepts. Basically, they reach the same conclusion. The prevalence of hand is still pretty high. It's about more than 40%. And the most severe for hand is actually quite minimal. One interesting finding from the meta-analysis is they found the CD4 CD4 is the lowest ever CD4 counts number with HIV patients. We found the CD4 actually has a strong, has kind of a significant impact associated with the hand. So we can come back to this at some of our study. The challenge for, I guess, for everyone at the meeting and also for everyone doing neuro HIV research is the hand has a high prevalence. So it's affecting nearly 40 to 50% of individuals living with HIV. And also at the same time, we don't have, if you compare pre and post CART, you say, yeah, we don't have much control or effective way to treat them. One reason is, of course, is their neural mechanism is not fully understood yet. We know better than 10 years ago, but it's still many more works need to be done. This is my research with MRI scanners. It's a type of scanner for people who haven't been done MRI. So this is like a subject lie down here, then looking at into the sky, and then we can get the imaging. So with our research, we are interested in several different types of MRI technique. The first one is just structural MRI. That's going to be a focus on my talk today, because I think we can only finish this part. Basically looking at the atrophy and different atrophy with different volume. Then you can have a diffusion MRI to looking at the fiber tract, because the fiber tract might also be injured, and with aging, with HIV, with other disease. And then also you can look at MRI spectroscopy. So that's why you can look at the different metabolites to see how the HIV disease or aging or other comorbidities might affect different metabolites here. And for many of our research is functional MRI, but I'm not going to discuss functional MRI much today. I think because we in the past, I already talked about functional MRI quite a few times, so that's one reason. Also with perfusion MRI, you can look at the blood flow or blood volume, and also you can look at the help you to identify the white matter injury, and like white matter hyperintensity, and something that will strokes. So as I mentioned today, I'm going to just focus on structural MRI. For structural MRI, basically we are looking at the what's the change, atrophy or volume or cortical thickness. So how this can be associated with affected by disease, affected by other factors. Today I'm going to just discuss two studies we did in our lab, plus one like a literature review. So we did back 2 or 3 years ago, we did a literature review on all the imaging study associated with structural MRI associated with atrophy. So this is done by 2 students. Sarah is a master student at the Catholic University, actually. Shiva is a IPN student at Georgetown. So we did a literature review. That's how we did it. We selecting all the, basically we downloaded all the paper published using structural MRI with HIV patients after 1996. So that means they are taking antiretroviral treatment or medications. So this is a technique we use to assess, because when you look at the different study with different doing structure MRI, one thing you notice is different study will have to report different outcomes. There are many possible reasons behind that one, because different study has different population. The demographics might be different, the age might be different. Some study like a WISE will focus on a woman with HIV disease. Then you have MAX focus on the man with HIV disease. So there are many factors can contribute to this kind of inconsistent finding, and also probably because of age difference, and the East, West, and other substance, and also their comorbidities might be different. So that's why we run the meta-analysis. We want to combine everything, say what's the most common findings. So this is basically analysis to identify region is mostly commonly affected in HIV patients. So this is we run different contrast. So we run HIV control versus cognitive normal HIV patients, and also just HIV patient, control versus patients regardless of the cognitive impairment or performance. And also we also looking at control versus cognitive impaired patients. And at the same time, we also looking at people with HIV infected individuals with or without hand. I'm not, because this is busy figure here, I'm going to just skip the one and focus on next one. So we're just looking at a subset of results here. So this is basically what it's telling us is across all the brain region, we compare HIV elective control versus patients. The frontal region is most likely to be affected. So compared to other regions, including to some degree, you can say the subcortical region, and then the cingulate also is the next. So it's like the frontal and the subcortical, and our limbic system is affected, more likely affected in HIV patients. Very interestingly, when you're looking at the patients only and then compare the patients with hand versus without hand, the sense is slightly different. Now you find that they actually people, patients with cognitive impairment, the more likely affected region is their subcortical and the limbic system. So of course, that's in the context of if we assume they both have frontal injury. But in that case, once you have a spinal injury, then whether you have hand or without hand, it's more likely whether you have subcortical injury. When you look at it, this is just looking at it very globally, looking at the frontal lobe, the limbic and the subcortical as entire box. Then we look at the sub-region within the frontal and limbic system. Actually, we find that anterior cortex is one region is most commonly affected in patients with controls. That can be how to say, it's kind of mean explain why we have some patients, even they don't have cognitive deficit, don't have hand yet. They might have some other symptoms. For example, they might have apathy problem because we know apathy is an emotion problem, depression. ACC is a really important region for this kind of problem there. And then when you look at the hand versus non-hand patients only, then you will find that the caudate within the entire system, caudate stands out as a region, has a strong contribution to hand. This actually is quite interesting because all this study is published after 1997 in patients who are taking antiretroviral treatment, because we know before 1997 there's quite a few studies. They already built a direct relationship between caudate and hand. So it looks like even after people taking antiretroviral treatment, caudate is still one of the key region might contribute or have an important factor, a role in the hand development. So this is the coming because this is more like quantitative data analysis. So we also run a qualitative data analysis. Basically, we reach the same conclusion here. It's like you can see from here. Caudate is the one. Caudate and pitumen and basically stratum hypho and cingulate. They play an important role to contribute to the hand. So based on this structure MI data, we propose a really simplified model to explain the hand severity, to use imaging as a marker. So our idea is we compare patients for control. Frontal injury is always there, but frontal injury in general, most cases are relatively mild. And this mild frontal injury can contribute to like a deficit in executive function or attention or working memory. Actually, it's like fits nicely with Dr. Spence's data, right? You see, find that really attention and process speed and working memory is affected. Suggesting this kind of mild injury is always there. But what's interesting, we make a prediction is to a large degree, the hand is still driven by the subcortical region. We did, of course, this model didn't exclude if individuals have a severe injury to the frontal region. Of course, this person will likely have cognitive impairment or be diagnosed with hand. We just say by large, if patients have cognitive impairment, more likely it's driven by injury to the subcortical region instead of the frontal region. Even frontal injury is most prevalent and contribute to more mild cognitive impairment. So we have get some data to supporting this simplified model, but we are working to in future to revise this model because we, for example, one region we didn't really touch much is thalamus, because we know thalamus actually is often impaired in HIV infected individuals, but because of just some mathematical reason, so we cannot really assess the role of thalamus in this model. But it will be integrated in future. So summary from the meta-analysis is basically, as we say, frontal injury is highly prevalent in patients, but the hand status is better predicted by injury to the stratum and the caudate region. So this will probably have, if we can really conduct additional studies supporting this hypothesis, might have some implication in when we treat patients, what's the best way we can treat them. And so, of course, that is the literature review, and it's based on other studies. And then when we think of the list of brain atrophy, then we say the ACC is anterior cingulate cortex is have atrophy, or the caudate or the stratum has a atrophy or frontal atrophy. Then what's the cause? There's probably different reason, right? Maybe because of their have immunosuppression, is a current immunosuppression, or historically they have a severe immunosuppression, or because maybe they have comorbidities like diabetes or hypertension, or maybe some other reasons, right? Many factors can contribute. So the first study we starting with the clinical factors, like the disease factor, like loss of CD4 can link to, or contribute to this kind of brain injury. So this is studied by Shiva and Kyle. Shiva is an IPS student, and Kyle is a postdoc in I. So this is our description, our contract. Of course, as you guys can see, right? Compared to you guys with a combined max wise cohort, ours sometimes much smaller. So it's, that's why we when selecting our subjects, we try to minimize some confoundings. So like people have untreated diabetes, we will have to exclude them because we know diabetes have some impact on the brain function there. Also, we have some other exclusion criteria there. So in this study, we're looking at the cortical thickness. Cortical thickness is the distance between the white matter, gray matter boundary to the gray matter and PR surface. So it's the cortical thickness. This has been very sensitive assessment of the gray matter injury or gray matter integration. So what we found is CD4 actually is linked to widespread cortical thinning. As you can see, it's really strong impact in the frontal and in the temporal region, and to some degree the precursor and the cingulate as well. So this is a base p-value. So this is based on what we know, probably this is one of the first study to really link the low CD4 to cortical thinning using the very stringent ratio here. So then this is a different way to present data. Basically, we say how much change if we have CD4 every 100 drop. I think it's every 100 drop in CD4. We want to see how much cortical thinning will happens. So it's like for some region you have up to 4% with 100. If your CD4 is 100 less than others, your cortical thinning will be maybe 4% by average. And then we also look at the, because we care about the cognitive performance, right? So this is an assessment with, as Dr. Spence just mentioned, we have this we call global deficit score. Sometimes we use GDS, or sometimes we can also use global mean T-score as well. But here we use the global deficit score because we want to see a clear difference between hand versus non-hand. So when people have a deficit score greater than 0.5, they will be classified as hand. If the people with GDS score less than 0.5, they will be classified as non-hand. As you can see from here, is a front region have really interestingly have a correlation with GDS score. This correlation actually is also true in non-hand subjects, suggesting that frontal injury might contribute to this kind of mild cognitive injury even before they meet the definition of a hand. But the frontal injury is there, as we just mentioned. Frontal injury is so prevalent, so the mild already is there and contributes to this kind of mild injury. And so summary, so basically CD4 is associated with widespread cortical thinning, as we mentioned, especially in two regions, particularly affect the frontal and temporal region. And this kind of mild cognitive deficit might be associated with reduced cortical frontal cortical thinning. So that's also provide some evidence to supporting our hypothesis there. So frontal injury is really prevalent, and it might contribute to this kind of mild injury or a mild cognitive impairment. Like impairment, we should say mild cognitive decline. Because by strictly we cannot say they are impaired yet. So now we just say, okay, clinical factors like CD4 count or CD4 counts. We also have some data suggesting CD4 counts. Currently, CD4 counts can also contribute to chronic kidney, but data is not shown here. But how about other comorbidities? For example, we know the prevalence of depression, a major depression disorder, is much higher in individuals living with HIV disease compared to the general public. So there is some recent some very comprehensive study suggesting it's more like 2 or 3 times higher in terms of prevalence. So that means many individuals living with HIV disease might also have this kind of impact due to depression. So in this study, I want to understand whether depression is also associated with a change in brain structure or in brain health. So this is studied by Margarita. So she's a master's student. She was a master's student just graduated last year and to postdoc. Actually, we just get this paper accepted. So it's we have 100 sample size. So you can see from here we have individuals we classify them as depression or without depression. So the depression for this our study is mainly is purely diagnosis based on the BDI score, Beck's depression inventory score here, second version, because we don't have the clinic psychologist in our team locally, so we cannot have an interview and to put it really full a clinic diagnosis. So we just use BDI score as more like this depressive symptoms, whether how positive they are. The cutoff score we use here is 10, but we also run some sensitivity and dependencies. We find that we reach some conclusion if we use different threshold. So what we found is quite interesting. We found depressive symptoms, like here with BDI score, is associated with hippocampal volume loss in adults with HIV disease. Why this is interesting? Because if we go back to just looking at depression in general public, in people without HIV disease, you will find the single most consistent finding in terms of brain imaging and depression is the hippocampal volume loss. But to our surprise, there is not much study going on in the HIV field. It looks like our study might be the first one actually to really report this kind of robust depression associated with hippocampal volume loss in HIV patients here. We find that 3 cluster is the cluster is typically associated. We know from literature is associated with depression. We have orbital frontal, then we have bilateral hippocampus. Out here, we only have, after the correction for multiple comparison, we only have the right hemisphere survive this threshold, survive the correction. So we run pretty stringent correction here. So after we run a correction, only the right hemisphere is survived. Then looking at the PDI score, of course, since that's how we define this cluster, right? We expect there's a strong correlation between the BDI score and the hippocampal gray matter volume here. But it's less to show it's not driven by a few outliers. And then because the RBDI score only capture what happens in last 2 or 3 weeks. So what about a lifetime depression? Where people with lifetime depression, where they have more likely have a lower or reduced hippocampal volume. At least in our study here, we found that the impact of lifetime depression is actually quite minimal. It's not significant. Even there is this weak, really weak trend. So basically, it's like suggesting the hippocampal volume loss actually is driven by current depression symptoms, not by lifetime depression history of lifetime depression here. Even you see some weak trend here. Another thing is we also want to understand whether our data, our results is driven by people taking antidepressant or not, right? Because we know antidepressant can, in some people, can be very effective to treat the depression. But at least here in our study, we didn't find any difference between people taking antidepressant or not taking. This actually is makes sense here, because if we looking at a large sample study with general population, like people, when people have, when people running clinical trials to get FDA approval with different types of different brands of antidepressant medication. If you look at all the study, in general, people find antidepressant is more effective in people at more advanced stages of depression compared to people has more mild depression, because in our sample size here, our individuals in our group, actually their depression is pretty mild to a large degree. So that's my suggestion why antidepressant is not, we don't see a difference, because antidepressant is not very effective in treating mild depression. And also, since of course our sample size is so unique, they have HIV disease, then the next question is asking, even depression, because this can have associated with hippocampal volume loss, where the disease factor, like as we just showed, right, later CD4, where later CD4 later, where they also contribute or interact with depression in affecting the hippocampus. Very interesting, we find that yes, CD4 later will have association with hippocampal volume. But very interesting, they seems to be like acting in parallel with depression. So this two is, they don't have interaction. So this is the regression line with people without depression. This is regression line with people with depression. And then this is just across all sample size. Looks like suggesting these two might act independent from each other, at least in affecting the hippocampal volume. This is more like just looking additional data, looking at sub-region. Yeah, but interesting. One point out is very interesting. Entorhinal cortex is one region has strong impact. That might also fit Dr. Spence's data. She just show the verbal learning is the one really affect the most, because that's where one of the important functions is entorhinal cortex. We don't find much significant difference in left for some reason. Of course, that's we have such a small sample with 100 subjects. So summary of this study is basically similar to the general public. We find that depression is really associated with hippocampal gray matter volume in adults with HIV disease. So this is good. This is good to know, because we don't find any other published study also finding similar findings. So that's good to confirm. Both HIV infected population and HIV uninfected general public, they share some common neural mechanisms here. And also HIV disease severity, like low CD4 later, actually contribute to additional volume reduction. But the key is actually based on our studies, looks like it will be independent of depression. This also fits some other study, like a recent review by Rubin and Mackey. So they find that when you look at just look at the cognitive function, there seems to be a disease, HIV disease and depression, there seems to be acting independent of each other. There's no interaction. Today I would like to have time talking all other modalities. And also we, of course, with the functional mind, efficient mind, other imaging technique. But then why we want this, right? Because the big question is when we study, first, from my perspective, is from my as an imaging person, what we can help to identify the neural mechanisms as underlying hand, how we can help, can we identify targets for treatment? So that's basically is our one reason we use very simplified model. It's I think it's very likely this model is probably to a large degree it's not it might not be accurate, but essentially it's just as first model to promote some kind of idea here. And this is more, of course, as mentioned, yeah, based on the meta-analysis here we did. Then also I just discussed, right? When you have injury can be caused by HIV disease, like CD4 later, a history of severe immunosuppression, or can be caused by comorbidities like depression, because we know depression is highly prevalent in individuals with HIV disease. I don't talk about our studies can also be like host genes can also play a role in affecting the brain health of the individuals living with HIV disease. For example, here we show ApoE4 and the disease severity actually they interact with each other, so they have interactive effects. But suggesting some individuals carry certain types of genes might be more vulnerable population. HIV disease severity might make them more vulnerable to dementia or cognitive impairment. Then, what we can help? Also, what we can understand. This is a study actually done by 2 undergrad students in my lab. We just received a minor revision today, so hopefully we can respond and hear back soon. So in this study, we did another literature review with MR spectroscopy. We found it's in the cut area. So once people receive cut, the hand is more likely, or cognitive impairment is more likely driven by neuronal dysfunction rather than neuroinflammation. Neuroinflammation contribute, they can be associated with the hand, but it's how to say, it's much, the neural dysfunction have much stronger role and much robust, consistent role in terms of impaired function. So suggesting like when we say in the beginning, right, we show the pre and post cut, the prevalence of hand is not much change. Suggesting this kind of neural function might still persist even people receive a treatment. So this kind of neural dysfunction might contribute to the hand because the contribution from neuroinflammation compared to neuronal dysfunction is much weaker. And also another thing we want to do with neuroimaging is can we identify biomarkers for hand, right? So we know for behavior testing, like using neuroscience testing, it's going to be time consuming. It's going also, there's some, as you guys are dealing with longitudinal data, you know, there's the practice effect, or sometimes a subject may be in bad mood. So it's like, it's both objective and subjective at the same time. But if we can have some biomarker, so we can do a scanning and predict some kind of cognitive performance, probably is one since we, as our lab has been pursuing. This is also recent publication by a postdoc. So we find that there's, you can see we can predict well. P-value looks good, experience P-value here, but at the same time, there's a high variance. That means more work to be done to really for us to be at the individual level to predict the hand, whether they have this person have hand or not hand. Yeah. So that basically is our research doing at the same time. Yeah, as mentioned, it's mainly we want to identify different causes of injury caused by disease, comorbidities, or host genes, how they can affect the brain function or brain health in HIV patients, and also what's the mechanism can contribute to this, contribute to harm, and what can biomarkers can use to help to monitor or to help to with diagnosis, and also with this one, how we can be identifying potential neurotargeted treatment. For example, we recently did a pilot study based on our literature review with structure MI. We identify the anterior singular cortex and the frontal region as a more likely affected HIV patients. So we did a double-blind single TDS study. This done with our colleague Peter Tuckhoff. So we want to say, if we can use TDCS to target the region mostly commonly affected in HIV patients to help them to improve function. Unfortunately, because of the pandemic, we so far won't have 11 subjects, but we're gonna probably just submit what we have as a small publication, and hopefully we can get additional funding. But so far, it looks quite interesting. We see some like robust effects associated with the region we are targeting. And this is basically a recent state connectivity suggesting it's a region where the region we are targeting. Actually, we see some changes associated with region, and also at the behavior level, we see something similar change there as well, and also it's associated with the brain region we're trying to stimulate. Of course, I cannot do all the work, so it's work by many people. Oh, sorry, it's running out of time. As always, that's my bad habit here. And this group of people, talented people in my life, and also thank all my collaborators at Georgetown, UCSD, and DCC for. I want the wise. It's really, I think, simple and very young. And back as when I first met Miss Mary, that's about 8 years ago or something like that, or 9 years ago, and then with Maya and then with Alan, I think we sit together, discuss how we can use the imaging technique to study HIV. That's really the start of my career in this field. Yeah, and I'm really deeply grateful for all you guys for the support here, and of course for our chair department for you guys supporting our research. Yeah. Okay, I'm sorry I'm running out of time. I should put a clock on my screen.
That's okay, Jean. It's so
Yeah.
exciting. I mean, and it's amazing how much you're able to do and the glimpse that you get. And, I think correlating the clinical parameters with the brain images and cognitive dysfunction is really, I mean, it tells such a rich story, and you've done such a great job building on, all the different layers. So I think you really outstanding. I think.
Oh, thank you.
Yeah, brilliant work. We're so glad that you're doing this. When you do imaging on the participants, we know it's not an easy undertaking, and thank you for showing that little tube that you have to slide people into. And there are a lot of people who have claustrophobia and have a hard time doing that kind of study, but they do it because it's so important. So
yes,
thank you. And you haven't even shared the functional MRI imaging type of work that you do. So everyone stay tuned. But any questions for Jean before we wrap up?
Yeah, I'm sorry again. I really think I should put a clock on my screen so I know the time. Yeah, just I finished it. I was it's 6.
John, do you know if the changes in your imaging and hippocampal volume actually later at postmortem reflect a loss of neurons, or I mean, has anyone done that correlation?
Oh yeah, Cassie, thanks. That's an excellent question. So far, of course, because as I mentioned, the depression even below depression is highly prevalent in HIV population, but not much research actually going on with imaging. Also with the postmortem study, but if we're talking about general public, the most consistent suggestion or conclusion is the more likely driven by loss of dendrites and the synapse injury rather than neurons per se. Yeah.
Synapse injury.
But you don't think that has? Well, you and I'll debate whether that has to do with neural inflammation, and when we see each other in the hallway.
Yeah, we can see each other. Yeah. But I think you raise a good point, because neural dysfunction can be driven by neural inflammation, right?
Well, I mean, microglia phagocytose synapses a lot, so that's our hypothesis. Okay.
Yeah.
We'll see how Sean's data comport with your data eventually. Okay.
Yeah.
Cool.
Jean, have you looked at things related to stress hormones and some of these parameters, which may also correlate with depression?
Fortunately, we don't have. When you say stress hormones, you mean the markers?
Cortisol, yeah.
Yeah, we don't. We with the funding, we in the first project we did. We collected the data. We collected the sample. You probably mentioned we can get some data, but we need to find money to do that.
Yeah. Because some of that HPA axis may be really important to look at too, is how it. Because you're right. I mean, and some of these depression, stress disorders, etc., may be strongly correlated as well. So, your depression marker may be actually a good correlate for something else that may also be contributing.
Yes, I agree with you. Yeah, it's like if we have, if we can get some additional money, I think different the direction. I think probably we can work together because we do have some subjects who are also part of the WISE. Maybe we can even just look at the pilot data there, say how that can predict the change there. Yeah.
And yeah, looking at change over time, and then looking at some of these biomarkers in those who have kind of stable hippocampus size and those who actually have a change. And it also there could be good synergy with what Blair is finding, especially seeing as some of that, the verbal learning and some of these other pathways is what she's finding are affected over time. So, and who we choose which drugs for is often driven by maybe some of these other cofactors, because we don't want to put someone with major depressive disorder on an NNRTI. So maybe they're on a different drug because of some of these. So very interwoven. Any questions from anybody else? I don't see anything in the chat.
I have a question. It may be a basic question, Jean, and maybe an obvious answer that I just don't know. But the question of neuroinflammation I find very interesting. Are there ways to? I know you can do spectroscopy, which measures you can do metabolomics, but are there ways to do like molecular imaging for neuroinflammation?
But that will be, if you want to, you can also do PET scanning, but that will be, so you can do PET scanning, or you can click in CSF is also another way. But CSF collecting will be everything. Most participants will probably hate if you do CSF collection. We are afraid that we might turn away participants, so we don't do CSF collection. So also PET scan is also another possibility. Otherwise, if MRI using MRS will be more like non-invasive, so it's safe. You don't have radiation. You don't have CSF, lumbar puncture. So, yeah.
Okay.
But if you have CSF data, wow, that'd be great. Yeah. I know you guys might have. Yeah, you guys have like this. Not everyone, but you guys have like large sample size there with CSF. So it would be quite interesting there. Yeah.
CSF is always a challenge to get.
So far, we're going to get one CS lumbar puncture from one subject.
You said one subject?
One subject. So we cannot do anything. Yeah, only have one. Yeah. No, it's just beside the slope. Yeah, it's a huge problem. Yeah.
I have a question.
Sure.
Are you
hi. Yeah.
Hi.
Hello.
It's Marjorie.
Yeah.
Are you separating the age group when you're looking at atrophy to determine whether HIV accelerated compared to normal aging of your individual? Are you stratifying?
Yeah, that's an excellent question. We only add age in our data. We only add age as covariates. So we do look at how age will affect the brain structure. Yeah, age has a strong impacts. Sometimes age impact can be stronger than HIV disease. Yeah, but whether we can say HIV disease might accelerate the aging in terms of the impact on structure. We are still working to recruit more controls so we can make a conclusion, or at least with the data we have, we didn't see that kind of difference there.
Thank you. Yeah, because it's a big deal, right? To try to differentiate the type of neurocognitive disorder that's caused by HIV versus just normal aging.
Just maybe, yes, yeah. And also how the aging and HIV were interacting with each other. It's quite
so my other question, my other question is a very technical one. I'm just wondering, how are you just going back to the patient records to get the data regarding their CD4 counts and even what was mentioned in terms of, I know you didn't measure CSF, but where is that data pool coming from? Is it a cohort thing, or are you contacting back the participants provider to get that data?
For CD4, we're collecting blood samples so we can get a current CD4 counts. For CD4 leaders, we have to ask them, but because many of our patients, they have a disease probably 20 or 30 years ago. So because back then it's impossible to reach their medical record, so we have to ask them, and also they will be willing to provide information. Yeah, and also I think some other study looking at the self-reported findings is pretty accurate.
So just regular kind of surveying. So is that how you get the depression score as well? Because that's
depression will be you have to run a Becky inventory. So it's more like a testing. So you have to run a testing, then you can you need to have a person trained with running. It's called the instrument called Becky's depression inventory. That's a psychiatric instrument. I think it's you might I don't remember we downloaded from online or we actually purchased. I think some of testing is you can is freely available like Mocha or MSE, but some of testing you might have to purchase their copies. So for the Becky's BDI, I don't remember whether we just download from online or just we purchased it. Whether it's free or not free, I don't know. Yeah, it's been years ago. Sorry, I forgot.
I got you. No problem.
Yes.
That's technical.
Yeah.
Great. Well, I
Thank
think
you for a very nice talk.
Oh, thank you. Thank you for coming in.
That's okay. Thank you so much. It's great to have the discussion, and thank you all for staying late and engaging. And again, you know, collaboration is key. If there's information about things that we use in the WISE to collect information that we can share with people, please feel free to reach out to us. There are standardized forms that we use. We use the CESD for collecting depressive symptoms, but there are other measurements as well. And going forward, we'll actually be doing the CIDI to actually make mental health diagnoses in our next round. So Zhong, I think that will be also very helpful and will allow you to pull people with specific diagnoses. So good, thank you so much. I'm glad we had the breadth of clinical and basic science people, and I think good ideas generated for future directions. And we can always convene meetings offline to get groups together to talk more about what we can do to support people's research. And then please also have bring in junior people to start doing some of this work with you and train them. And we do have developmental funds to support those kinds of activities. So
that's great.
Yeah.
Okay, we definitely Dr. Spencer, Blair, we should discuss, and Symbol, we should discuss more there. That'd be really
Pilot
interesting
awards,
to dig data.
Yeah, developmental awards. So great. Any last thoughts? Otherwise, we'll wrap up. It's 6:19.
Yeah, sorry today.
That's
and
okay.
Gary, good to see you joining.
Thank you for joining, Gary. Any words of wisdom from you, Gary, about neurocognition and HIV and the work that you've heard about today? We think you're there. Hopefully someone didn't grab you away from your computer. It's always possible.
Yeah, it's already there.
These were great talks, though. Thanks to you both.
Thank you guys so much. Thank you. And thanks to everyone for joining.